today to our ECHO presentation and case study. I'm Karen Stevens, and I'm a registered dietitian and have worked with weight management for many, many years. And I am covering for Sarah Hampel today, who is out of town. And so we miss her, but I'm happy to be able to cover for her and to lead this great ECHO. I'm really excited about our topic today. And so we'd like to start today with introductions. And so we'll start with our ECHO team. And so we'd ask Deb Schumer to introduce herself, and then Julie Bernard.
Debbie Schumer, I'm a dietitian in Southeast Missouri. Thanks for the food care system. Glad you're all with us today.
Thanks, Deb.
Hey everybody, I'm Julie Bernard. I'm a pediatrician and a weight management specialist down in Cape Girardeau, Missouri with St. Francis Healthcare. Thanks for joining us.
Thank you. Amy Braddock and Christina Fernandez.
Hey everybody, Amy Braddock here. I'm a family medicine physician at the University of Missouri in Columbia and a pediatric and adult obesity researcher. Great to see everyone.
Christina? Well, we'll go ahead and go on. I don't know if you're muted, Christina. We can't hear you.
We got a message from her earlier that said she would only be able to listen today.
Oh, okay. I'm sorry, I didn't catch that. All righty. So we'd like to have the members, the participants, introduce themselves if possible. And so we'll start with Adrian Ortega and then Heather Allen.
Hi, I'm Adrian Ortega. I'm a psychologist that works within weight management at Children's Mercy.
Thanks, Adrian. Heather?
Heather Allen with the Missouri Children's Division.
Excellent. How about Katie Cox and Mary Beth Schillinger?
Hi, I'm Katie. I'm one of the nurses with Children's Mercy Weight Management.
Thank you.
Hi, I'm Mary Beth Schillinger. I'm a licensed clinical social worker, and I'm a behavioral health consultant at the Family Medicine Clinic in Columbia, Missouri with MU.
Thank you. Thank you for joining us. Rachel Ward and Renee Arnsberg.
Good afternoon, Rachel Ward. I am an LPC in Southeast Missouri with FCC Behavioral Health.
Great.
Hi, I'm Renee Arnsberg. I'm also a licensed clinical social worker at Children's Mercy Weight Management. I work with Dr. Hampel.
Thank you. Robin Harwell.
Hey everybody, I'm Robin Hartwell. I'm a registered dietitian with Missouri Highlands Healthcare, and today I'm at our clinic in Eminence, Missouri.
Great, welcome. I don't see any other participants. Is there anyone that I missed? But I did miss part of our team, Brianna Sapp. Brianna, will you introduce yourself, please?
Hi, good morning, everyone. My name is Brianna Sapp. I'll be your ECHO coordinator today here with Missouri Telehealth Network and Show Me ECHO. If you have any questions regarding this ECHO or any of the other ECHOs that we offer through our program, feel free to reach out to me. Also, if you're needing access to SharePoint, which houses materials that we present on the sessions, I can help get you set up with that as well, and I'll make sure that my email is posted in the chat for you all.
Thanks, Brianna. So just a few reminders before we get started with our presentation. If you can open your camera, we would love to see you and have you participate that way. If not, that's fine as well. And then we'll have the presentation, and afterwards, if we have a few minutes for questions, if you'll hold your questions until then, or if you've got comments that you want to add to the chat, that's fine as well. And so I'm going to go ahead and turn over the time to Julie Bernard. She's going to be presenting today about obstacles we find in families. And I've been very excited about this because she's an expert and has a lot of experience in it. And so, Julie, go ahead and take it away.
Right. Can everybody hear me okay?
We can't see your, oh, there we go. Yes, we can.
Sorry, there's a little bit of a delay. Should be pulling up the slideshow now. Okay. Can everybody see the slideshow version? Okay. Very good. All right. Well, thank you, Karen, for that introduction. I certainly do not feel like an expert when these things come up in clinic, but these are some pretty common scenarios that we see that complicate the care of pediatric obesity for our patients. So the particular scenarios that we'll talk about today, the disparaging parent, unrealistic expectations, split households, and then the saboteurs in the family. And so we'll start with a little bit of audience participation. You guys can either unmute or answer in the chat. How often would you say you experience one of these scenarios in your practice? Regularly, weekly, yes. Very good. I would say quite often, 2 to 3 times a week. Yes. So as you can see, these are not uncommon scenarios that we come across in our weight management visits. And so we'll talk a little bit about how to handle some of these because they can definitely make things more difficult. So just remember before we really get started with this talk that weight stigma is common for our patients in most of the aspects of their life. Family members being the most common sources of stigma. Doctors or medical providers are right up there as well as classmates and friends, other members of the medical community, as well as teachers. So these kids are experiencing a lot of weight bias, but they are getting most of it or a good amount of it from family members. And that can occur both at home or in your office as well. And so just some common examples of things that I hear from family members. So like you have a patient that's on the scale and the parent may say, oh, I just know she gained more weight today. Or they may say something in the room to the child like, I told you you need to make better food choices. You can't keep eating like this. Or a lot of times what I'll hear with physical activity is, well, he's just lazy and unmotivated. I can't get him to exercise. One particular difficult situation that I had with a family once was a mom that told her daughter, who was probably early childhood age, you don't want to get fat like me. And so these are all things that are really tough to hear from a parent to a child and as a physician who's trying to help this family. And so these are things that we really try to address during these visits. And remember that a lot of these statements are probably because of the very common still public perception of obesity, which is basically that somebody has a weight problem because they don't have willpower or they make bad food choices or they're lazy and they just need to eat less and exercise more. And unfortunately, in the case of pediatrics, a lot of blame then comes on the family or the parenting, and people may blame the parents for their child's weight concerns. And so this can lead to a lot of defensiveness on the part of the family and may trigger some of those comments that you're hearing if the parents are just really frustrated with how this weight journey is going. And so ways to combat these negative statements, acknowledging that it's frustrating. It's really hard to set up healthy habits, but remembering that obesity or weight gain is not a personal failure, it's a health issue. And then focusing on small victories. Maybe the scale didn't change much or it changed in the wrong direction from what the family was hoping, but maybe the child's being more active or they're starting to watch portions a little bit more. And those are still great things that we need to celebrate in order to kind of keep the family and the patient on this weight loss journey. Focusing on health, remembering that self-worth is not based on weight or appearance. And that's what the quote is kind of getting at on the side, that we really want family members to impart on their kids that while this is a health issue and we want to make sure that we're addressing this, we don't want their self-worth to be wrapped up in that number on the scale. And remembering remembering that health can improve even if the number on the scale isn't changing if we're making lifestyle improvements. And then just helping families to develop positive self-talk, positive communication around their weight and their health, making sure that we are using patient-first language and encouraging families and patients to do that as well. And then just a reminder about the complexities of obesity. If it were easy to lose weight, then we wouldn't have the epidemic that we have with obesity in this country. And so when do you address these statements? And I think this can be a really tough one because while you want to preserve the self-esteem of the patient and you want to address these concerns, you also don't want to alienate or anger the parent that made these comments. So it's kind of like walking a fine line of trying to maintain a balance with everybody in the room. But we really do want to address these statements pretty immediately and just point out to families that they can be harmful and further weight bias, and that can lead to low self-esteem or depression. It can lead to unhealthy or extreme weight control measures, binge eating, and unfortunately, these comments from family members we know are internalized more than other comments that may come from other sources of weight bias, and they will occur in adolescence, but these thoughts and these feelings can follow them into adulthood and affect their adult health as well. So some of the common examples and then ways that we could maybe diffuse the situation. So when the parent says, just know she gained weight, you could say something like, gee, it seems like that's really frustrating for you. What made you feel like the patient had gained weight today? Or even just directed to the patient at that point, did your weight surprise you today and why or why not? And that could get the patient kind of talking about, well, I didn't reach my healthcare goals that we set the last time because of X, Y, and Z. So it might get the patient talking a little bit for themselves. Or when a parent says something like, I told you needed to make better food choices, it sounds like maybe we need to set some nutrition goals. What goals do you think it would be reasonable to set as a family, or again, directed to the patient so that they're taking charge of their healthcare? How do you feel about the nutrition choices you're making? And let's kind of explore that a little bit. Let's try and figure out why you're making those choices and if we could maybe improve on them a little bit. Or when, and this might be the most common one that I hear, well, he's lazy and unmotivated and he won't exercise or she won't exercise. I try to remind families that exercise or physical activity can be really uncomfortable for patients. If they get really short of breath while they're exercising, do we need to look at maybe there's an underlying asthma diagnosis? If they're tired, is there some underlying obstructive sleep apnea or balance issues? Are they having pain at all that makes them not want to be more physically active? And so directing some of those questions towards the patient may get a little bit of input as to why they're not being more physically active. And I feel like sometimes if we can just address some underlying health conditions or some physical concerns, sometimes that helps the family just to be a little bit more understanding about how uncomfortable physical activity might be for the patient. And then also keep in mind that there may be some mental health concerns going on. If a child's been bullied in a locker room or made fun of during PE or recess, they may have some really negative feelings towards activity that make them not want to be as active as well. And you don't want to get fat like me was actually said when I was not in the room, but I could hear the family talking. So that was a particularly difficult one to address, but really just trying to get to the health concerns that the parents might have for their child, or really just addressing any negative experiences that the parents have had towards weight bias might break down that barrier a little bit and help to diffuse that comment. And so now we'll talk a little bit about unrealistic parent expectations. Keep in mind that children that struggle with obesity tend to be taller than average for their age, and that can make them appear older and then increase expectations out of proportion for what their age actually is. So we have a lot of parents who will come in with their kiddos who are in like the 7 to 9-year-old range and expect them to really be taking charge of their nutrition intake and making healthy choices towards towards like fruits and vegetables. And that's just not necessarily reasonable, especially at the age that those kids are. And reminding families that making changes and remaining consistent is really difficult, especially if you guys have food environments that are not conducive to making those healthy changes. And especially if the entire family's not on board, it can really make it hard for the child who is in the weight management care to make those healthy changes. And so we talk about like trying to get the entire family on board, keeping food or drinks that are in the home for parents, and that the kids are expected to stay away from, trying to keep those like up high or away from the kids so that it's easier to make some of those healthy decisions that the parents are wanting them to make. We know from studies that in traditional family-based therapy programs, 2 of the major predictors of a child's success in weight loss is their home food environment, and then also parents helping to monitor the children's healthy habits. And then parent weight reduction or BMI reduction is a really good predictor of positive weight change for the patient as well. And so that really strengthens this idea that the parents can be good role models and that they play an important role in their child's health journey. And so ways to help set more realistic expectations at home: remember your SMART goals and that smaller changes over time are more realistic than setting these huge goals that seem really unattainable, especially to kiddos. So doing goals that are specific, measurable, attainable, realistic, and time-based, the SMART mnemonic can be really helpful. And then it can also help to just encourage parents to continue to role model that healthy behavior, so that instead of being the food police or constantly nagging their kids or feeling like they're nagging their kids to make the good choices, they're doing those changes right along with their kiddos. And remember that the MyPlate guidelines are recommended for everybody to promote overall health. So as we're talking about these nutrition recommendations or physical activity recommendations for the child, it's really great if the entire family can start to make these changes, and it usually improves the health of the entire family at that point. And then setting boundaries around food or occasional treats, making a visible meal or snack schedule can all just help to decrease that conflict that parents might constantly feel that they're in with their kids if they're really trying to set up some healthier nutrition habits. I know even in my home, we try to schedule a dessert night or 2 per week, as opposed to constantly arguing about when we're going to have dessert or treats after dinner. And that just kind of helps everybody to be on the same page as to what the expectations will be for that night. And then managing expectations for weight loss as well. Remember that a lot of families may come in with different ideas or different expectations for how much weight their child is going to lose or what success is going to look like. And that we might not necessarily reach the goals that they had in mind when they started, but we may need to manage those expectations and set more reasonable goals, especially for kids that are still growing in height. Remember that just keeping their weight the same and growing taller will help their BMI. And so sometimes I have to remind families that we're not really looking for a change in that scale. We're looking for a change in height, and then the body mass index will follow. And again, even if we aren't seeing changes in the body mass index, just changing some of those lifestyle habits can promote better health, even though we're not seeing those changes in numbers. And reminding families that these are meant to be lifelong changes. They take time to develop. It's not something that we want to get set up right away and then they'll do it for a month and then be done. These are changes that we really want to have follow these kids throughout the rest of their life. Managing weight in different households can also be really difficult, especially if the different households don't have the same goals in mind. For patients, we do know that kids that have undergone some parental separation can be at higher risk for excess weight, and that owes to a lot of different factors, different living environments, changes in resources, both time and finances on the part of the families, different routines, more stressors, or more tension in the home can all lead to this excess weight. having the kids go back and forth between homes where there are different expectations or different activity and nutrition options available can be really difficult as well. And I've certainly seen in some of my patients where they may go to one home where the family is cooking most of their meals and really doing a lot of meal prep, and then they go to the other house and it's more just grab something out of the freezer and heat it up when you're hungry. And that caused a lot of frustration for that particular family. And different parenting styles too. We know that the authoritative parenting style tends to be the best for maintaining a healthy weight. But if one is more authoritarian or more passive with their parenting, that can promote weight gain as well. What's especially difficult, I feel, is when one parent accompanies a child to the visit and then points the finger at the other household because they aren't making the best activity or nutrition choices. And then it's just kind of a back and forth with the families attacking each other for the lifestyle changes that they are or aren't able to make in that home. So it's really important with the parent that's in clinic with the child is to focus on what they can control in their own household and validate frustrations, especially those that are made by the patients themselves. A lot of the frustrations with the family that I mentioned in the last slide, those frustrations were expressed by the patient himself and wanting to be able to make healthier changes in both homes. And so we really focused on what he could do that could be consistent between both homes and at school so that he felt like he was still making some good changes for his health. Be careful of documentation. I have certainly had times where I've written a note and put what one parent said about the other household in said note, and then there's a lot of going back and forth through the patient portal with regards to the other household trying to defend themselves and attack the original household. So that can really get you into kind of a back and forth there. And then just encouraging participation from caregivers from both homes, even if one family member is on the phone or virtually attending. That way they both have an opportunity to share what's going on in their household and they don't feel like the other home is speaking for them. And that can promote open communication as well. When we have a kiddo that we know shares time in multiple households, we will give 2 or more sets of information or handouts. So when we write down their goals, we will make a copy so that each household can have that handwritten goal. Or if we're giving informational sheets, we tend to give 2 copies so that each household gets the same information from us. And then saboteurs can be a little bit of what we just talked about with split households, but we also know that kids spend a lot of time with grandparents or other caregivers, or even within the home, siblings or parents who aren't necessarily participating in this weight loss journey can certainly influence the child's ability to make and maintain healthy lifestyle changes. And so, again, encouraging a lot of different caregiver participation in your visits can be really helpful. Discussing why everybody being on the same page and sticking to the same goals is really important for the patient themselves, and having a supportive family certainly makes that easier. And just remembering that everybody can benefit from eating better and doing more physical activity. So even if you have a sibling that does not have concerns for weight, encouraging them to continue on this journey with the family and the patient can be really helpful as well. And so making a plan with families to have conversations with other adult family members can be really important. I certainly have had patients that come in and say, well, in our household, we do this, but then they go to grandma's house and grandma likes to do this with them, or grandma does this with them, and not really knowing how to address those concerns with grandma. So kind of having a plan for how to get that conversation started can be really important. Again, sharing the information that you're giving to the families with with the other caregivers can be important as well. And emphasizing that it's not just the child's weight that we're worried about, it's really just their health overall. And then encouraging other activities. So if it's a special thing for the grandparents to take the child to a fast food restaurant once a week, maybe let's pack a picnic and go to the park instead, so that they're still getting that quality time, but they're doing it in a more healthful manner. Again, asking those family members that are not necessarily on board with the patient's weight loss goals to attend a session so you can talk more about the goals and how they're important can be really helpful. Having family members not keep the red foods, which some of those are listed in the chart off to the side, in their home, or keeping them up and out of sight if they have to have them, so that it's still more second nature for the kids to make those healthier decisions. And then just kind of through the family behavioral treatment coaching sessions, one of the things they can talk about is just who are the saboteurs within the child's life, and kind of how to manage those, any victories that they've had with those family members that seem to be sabotaging more. So those are some of the things that are discussed in the family-based behavioral treatments. And those are my references. Happy to share those with anybody. And thank you all for listening. And those are my sweet little kiddos that are pictured there. And I want to say thank you especially to Elaine Ganninger and Denise Wilfley, PhDs from Washington University, that helped with these slides. So thank you all very much.
Thank you, Julie. That was an excellent presentation. And we have a few minutes. If you have any questions that you would like to ask, we'll go ahead and take those now if you just want to open your microphone and ask them. Well, while you're thinking, I will ask a question of something that I've seen. Sometimes it's such a hostile environment when there's two parents that really do not have a good relationship with each other, that the air is thick and it's very hostile and accusatory. And sometimes one will say, you know, you shouldn't be bringing him here. You're telling them he's fat and he's fine. And the mother, they kind of go back and forth a little bit. I would just like Julie to share some of her ideas of how she would deal with a situation like that.
Yeah, and I would say normally when this comes up is probably the very first visit that I have with those patients. And so I would say if they're both at the visit, that's a really good sign that they have concerns for the child's health. So just kind of getting both of their standpoints as to what they're worried about, and then trying to find common ground is good. We just really try and talk at the very beginning about how this is not about body shape or size. We're trying to make sure that the child is healthy. If you have lab abnormalities that you can point out, or like concerns that the child has about, I can't run as fast as friends, those can sometimes be useful in kind of pointing out to the one family member that's more resistant to being there, like, well, hey, maybe, you know, we just need to change some nutrition stuff and we don't even need to talk about weight, but they would like to run faster. So let's just work on that as a goal. We certainly know that a lot of parents have concerns for prompting like the development of an eating disorder if we're talking about their weight. And so we really try to reassure that in a more controlled setting where they have a supportive environment and are learning healthy ways to control their weight, that's less likely to happen. Sometimes I've had to separate the parents and put them in separate rooms and kind of talk to them individually. It takes more time, and unfortunately we don't always have that, but just trying to do whatever we can to diffuse the parent tension is good, and ultimately reminding them that we're all there with the same goal to make their kid healthier. So we need to work together.
Thank you. That's excellent. I know I've had to do that before. Sometimes set some ground rules that we're here to focus on this child. And we're going to, you know, if we're not able to do it together, then we're not going to be able to continue this. And that seems to help sometimes get them calmed down. Any other questions besides from me?
I just wanted to say that was excellent, Julie. Just so many good tips sprinkled throughout that. I find that a lot of times it's a lot of like guilt and shame kind of in the parents themselves, both towards their weight and then kind of towards their child too. And so it's almost like they're trying to like justify, you know, what has happened. And so like you talked about just being good role models and the kind of language we use in the house around the kids and that self-talk and body image to really promote this like positive home environment. Sometimes I will also shift more towards like you talked about other health goals and not just the number. And family history seems to be kind of a neutral area. So if we talk about like what, you know, diseases run in the family that we want to try to prevent in the future, that seems to be more acceptable, like you were talking about, with kind of shifting that. So but yeah, excellent suggestions.
Thank you. And I find too, and this may just be anecdotal, but the more I see a family, like the more you establish that trusting relationship with them, I feel like those disparaging comments from the families tend to decrease or even disappear. I really think it's a defense mechanism. It's like we're embarrassed that our child gained weight, that we aren't making those goals that we talked about the last time. We feel like you're going to judge us. But the more that they get to know me as like, I'm just a resource and a cheerleader for you, basically, and I'm here to help, but I'm not here to say like you're horrible parents for letting your kids gain weight or anything like that. I really think that helps a lot too. So just keeping that weight bias in check, and just letting the families know, like you hear them and you know it's tough and it's complex. And like I said, if this were an easy thing to fix, they wouldn't need all of us working together to help. So just kind of letting the parents know, like we're all on this journey together, and I'm just here to help. So
yeah, thank you. Anyone else? You know, something also that can sometimes help if the child has gained a little bit of weight, particularly if they're growing taller, you show them the growth chart and show them their body mass index coming down. And that it's almost like sometimes they'll just like, they're so relieved. So I know we're all trying the hardest that we can to make good progress for these families. And so thank you so much for those ideas. Well, we are going to go ahead and go on with our case presentation today. We're going to have a case by Adrienne Ortega. And so Adrienne, if you'd like to share your screen, or if Brianna is doing it, we'll go ahead and start that.
Yes, it'll actually be mostly led by Renee and me joining in.
Oh, perfect. Okay,
Renee, do
Renee.
you want me to share or do you want to share it? You're muted.
You know what, Dr. Ortega, if you want to share it, that would be great. And then I can go through it. Do you mind?
Yeah, that's good. 1 second.
Okay. So while he's pulling that up, I'm we'll give you a little background. So I've worked with Dr. Hampel for quite a few years, and we have worked with this patient that she actually made the slide. So thank you, Dr. Hampel. She has actually worked with this patient for quite a few years, and I've been alongside her, and now Dr. Ortega, who's been very, very helpful. So just thought we would kind of go through the case, and then I know Dr. Ortega has some really good things he wants to share about what he's done from a psychology standpoint as well. So I will go ahead. So the reason we're presenting this obviously is to find out if anyone has other ideas or supports that can be offered to the family. I will share with you the family composition is the patient and the mother and the father. So there's 3 people in the home. Reasons for weight gain: excessive appetite, refusal to stay out of the kitchen, home environment scenario there, large portions, and lack of physical activity. Some of the contributing factors are hyperphagia, binge eating, ADHD, depression, and anxiety. And then some of the things that have been helpful is the patient has definitely benefited from changes to the home environment when mom, has made the decision, as Julie pointed out, to have healthier foods and not as many high-calorie foods and drinks in the home. The patient also, they live in a rural area, but they are somewhat connected. It's been intermittent with their community mental health center, and they have a caseworker there who sees them weekly. However, the patient has not had any psychotherapy for a few months. Patient began seeing Dr. Ortega on our team in early 2026, so January of this year. And they've been given some behavioral support to help with consistency of eating, routine, physical activity, sleep management, or sleep patterns, and those things to help manage hunger. The medications that Dr. Hampel has tried to peer mate, patient did not tolerate. And then the semaglutide, the patient had some side effects, constipation, prolonged diarrhea, continued high appetite, so did not have the satiety that we had hoped for, and weight gain up to continued weight gain with the 1 milligram dose is what they were on for the semaglutide. Next one. Okay, perfect. So the patient is 13 years old, class 3 severe obesity, with several medical and psychological comorbidities. And we began seeing him, I guess it was 2022, so it's been 4 years now. Family history, both mom and dad have obesity. Mom has actually had bariatric surgery. She had the gastric bypass. Both parents struggle with mental illness and hypertension. Mom has other health issues, including lupus, sarcoidosis, type 2 diabetes, congestive heart failure, and chronic lung disease. And then dad had a stroke in 2020 with partial paralysis. So most of the time when we've seen them telehealth, I've never seen him even be able to get out of the chair. So that's definitely a barrier. Some of the social determinants, food insecurity is a big one. The family lives, it's a rural property and they live in a trailer, and they have inconsistent electricity. At one point, they didn't have, their water was turned off, and or their hot water heater or something wasn't working. I can't remember exactly. So they were bathing with buckets of water, and there's a river close by, so we obviously address that. So it's a pretty detrimental situation with just basic needs being met is often a concern. Currently, they are in a safe place. They are living with the grandfather, and then dad has most recently been hospitalized with a kidney issue and may be going to a rehab facility, so he may not be returning home. Previous trauma for patient is bullying at school. There is a sibling who died of SIDS and dad with PTSD and the stroke, as we talked about. School has definitely been an issue. Patient was attending school, but due to excessive absences for various reasons, some of it due to bullying and some of it due to sickness, medical issues. So he has been homeschooled. He did also have a surgery this spring, and so it just was a better option for now to homeschool him with the goal to return. Comorbidities for the patient, untreated obstructive sleep apnea, hyperlipidemia, dyslipidemia, ADHD, enuresis, celiac, encopresis. And then she did refer to the surgery there in March. And then some of the mental health, depression, anxiety with history of inpatient psych admissions as well, with some SI and HI. Medications currently is sertraline, buspirone, guanfacine, and then the hydroxyzine is PRN, and no history of substance abuse reported. And we don't suspect that. And then here's a little information about the nutrition, which obviously our RDs have supported as well. They're not on today, but mom reports patient is eating frequently. Sleep patterns have been disrupted, so he's up a lot of the day and then gets up at night to eat. She does allow him to serve himself, and he often takes larger portions. And then if she does say something, she feels like, he gets upset because she's criticizing him, and then it affects his self-esteem. She's worried about because then, obviously he thinks he's overweight and fat. Mom and patient have been eating out more lately because of the disruption in the home environment with dad's hospitalization. Which has been, he's been getting more gluten, which obviously is not ideal for his celiac. So those have been some recent happenings. And then sleep history, stays up late. Screen time is very difficult with him. He gets multiple hours a day video gaming. And honestly, I have worked with mom for several years, and her own mental health is a big barrier. She is getting mental health treatment. I will just add this in. I don't think Dr. Hempel put it, but she is well connected with behavioral health services, but she struggles regularly. So sometimes setting limits is very difficult for her. He does get a little bit of activity. He does love his animals, and so he will go outside and walk and play with them. And then you can see the other barriers there that we listed and already talked about. She did put in a slide here for those of you who would like to see his growth chart with current weight and height out to the side, which puts his BMI at 49.49. So that's 193rd% of the 95th percentile. So pretty high BMI for a 13-year-old. Very high BMI.
And you can see based on, I mean, obviously there's a trend that's increasing here in terms of BMI, but if you look at some of the dots, there are some where BMI did go down a little bit, and that's when he was on the semaglutide and other medications, but those have been discontinued due to the side effects that he experienced when he was on those medications. So we're currently talking about restarting some medications, but we're just trying to be mindful of what are the best options for him and family, given the history and also all the other things going on.
Thanks, Dr. Ortega. And then just some final thoughts. I know some of you are probably wondering what agencies have been involved. Community mental health has been involved. There's Children's Division in Missouri has been involved. There's been multiple hotline reports, including by the school. And most recently, there was a report made, and Mom did give our team permission to talk with Children's Division, and we thought that, you know, something like intensive in-home services where Mom could get some additional support too, and setting up some things for success. Unfortunately, I'm having a difficult time getting a hold of Children's Division, so that's a work in progress.
That's mostly the case here, just from my end. So I just started meeting with this family in January. Like Renee said, we've only met for 2 sessions. One was more of a psychological evaluation, just trying to understand all of the mental health concerns involved for this family and as well as the family system. And then the last session we had to kind of focus more on some treatment, although there had been a huge disruption with his father being hospitalized and some of the changes with that. So we've just been mostly putting out fires is the best way to describe like our work so far. We've had pretty inconsistent treatment. So again, only 2 times since January. I do have a session scheduled with them very soon, so we're hoping to get more consistent scheduling. And we really have he was referred to me to work on eating behaviors, not necessarily the nutrition aspect, but more so of like trying to better understand his hunger drives, and working on addressing his dysregulated eating habits. As you can tell, there's so much going on with the family, and he's pretty much he has a really unstructured day, and so there's a lot of challenges then when it comes to establishing a more regular pattern and routine around eating, where it just becomes really dysregulated, where he goes throughout the day with not eating and then serves large portions and eats a lot at night, only further contributing to the concerns we discussed. And so a lot of the work we have done is it's just sort of establishing some structure and some consistency and routine in the household so that we can then make some progress with these health behaviors. And so I can leave this shared, or I can unshare my screen. We can talk all together. Maybe I'll do that. And if anyone has questions, I can pull up a slide if we need to. What county do they live in? Renee, do you remember? You're muted.
Oh, sorry. The Community Mental Health Center's Burrell. I'll have to look up. I can't remember. I'll have to look. I'm sorry. But their zip code for the community mental health is Burrell. Let me look it up while we're looking, because I'll be able to tell immediately. It's just escaped me.
There are some questions and comments in the chat that we can go to that maybe you can talk about while she's looking for that. Let's see. This young man has certainly experienced significant loss, and the potential ongoing loss of his father and his environment could be a factor toward loss. Just a comment. The county she's looking up. And then Deborah Schumer said, I have a situation where it was very difficult to get the parent engaged, even though questions addressed to the parent differing from those directed to the child. The parent would look to the child for all responses, even if specifically addressed to the parent. Any suggestions on that? Sorry, I couldn't verbalize this at work, and every time I ended my environment got loud, I was afraid my speaker would pick up. So that's a question from Deb Schumer about getting the child to respond versus just looking at the parent.
Yeah, I'm not sure that question applies to this case, right, Deborah? But we can talk about that maybe at the end. Come back to
Okay.
it.
I think that might have been a question for
out.
Julie, and I think they were having a conversation about that in the chat. It's
Okay,
confusing, yeah, when there's multiple.
Okay, very good. Yeah, there we go. Yeah, then they've got the discussion. I started at the top.
To the point about his father potentially being a loss in the environment, that is true. Father does I think family sees it as potentially a positive of removing a potential like obstacle in the household and getting him the care that he needs and to be supported by people who can care for him more adequately and appropriately than they can provide. But it will certainly be a change and in the dynamics as well. He really does rely on mother for a lot of supports. And I think she tries to have him be as independent as possible. And it's just an interesting dynamic in their relationship. And I can speak more to that.
And there is, Renee did put in that they're from Morgan County, Stover, Missouri. So for those who are asking about that. And then we haven't, go ahead.
So I was just reading this question here about what's his typical, do we have a sense of a typical day of eating? What is he eating? Yes, especially given that he has celiac. It is, I think the last time we talked about this, there's no breakfast really. And then around like lunch and dinner might be things like mashed potatoes or like macaroni and cheese, some protein, not a lot of vegetable. So it's definitely very carb heavy. I'm not entirely positive or certain, I can't say either way, that they're choosing like celiac friendly options when they're making things with like grains. So I can't speak to that.
Okay.
Thank you.
How about his mental status that Deb is asking here?
Let me look
What is
here.
this young man's mental status? He is in a state that he can make changes or be independent in terms of selections and self-care.
So cognitively, he presents typically is able to understand questions and respond and engage. He's definitely so I have no concerns about his overall cognition in terms of like his activities of daily living and sort of like criteria for intellectual disability. I'm not saying he's the most functioning kid out there, especially given all the concerns you've heard with this family. But I'm not concerned about his ability to make choices that might benefit him. It's just that I think there's so much dysregulation within the family that he's not suited or prompted to make positive health choices because there's a easier alternative for him to make. So in terms of like eating and whatnot, I think it's much easier for him to follow along and to eat when it suits him rather than to think about establishing meal times or to changing his behaviors because that's more of what fits in with his current routine and pattern. Renee, I'm not sure if you want to say more to that.
Well, I would just say too that, mom is so dysregulated that she herself is not able to sometimes even set up that structure for just regular meal times, which is what I was hoping maybe, even an IIS worker for a short stint of 6 to 8 weeks could be that support for mom. Sometimes she just needs somebody to listen and kind of help get her back on track. But when she's only seeing us, even once a month or 4 or 5 weeks, then she kind of falls back into her own, patterns. Mom has very limited support as dad hasn't been able to really help at all. So I feel like her own mental health impairments get in the way of her establishing that routine for him.
Yeah, and I think for this kiddo, so one second, Amy, like there's just a lot of shame and guilt around behavior change and like needing. So you might have heard Renee mention that if mom tries to tell him to choose smaller portions or to make different choices, then he sort of internalizes those things and calls himself fat or overweight and says that like thinks that like we're only asking him to do those things because he lives in a larger body and not necessarily to improve his overall health. And he's had some resistance about mental health therapy too. Recently, he's kind of come around and seen more value of it as he sees that there's benefit of it when he's been more dysregulated. But he kind of is his own self-saboteur sometimes. Um, yeah. Anyways, Amy, what were you gonna say?
Um, First of all, poor family, and that poor mom, and you guys are doing a great job of trying to support them. My heart goes out to them, and just like all the
Yeah.
struggles that they're going through. I was just curious if you knew more about why he was taken out of school, if it was just about bullying or if it was a transportation issue, because it seems like that would be a great first step if to get more structure and access to a healthy environment, but there might still be other barriers to get that going. And also just to get some relief for that poor mom, because if she's trying to homeschool him on top of everything else, I mean, no wonder she's at wit's end.
I should clarify, Amy. Sorry. He is like on homebound. It's not an actual homeschool program. So he does take the bus. Some of the barriers, we would love for him to be in school. And I know school has worked with them tremendously to get him there. But a big barrier is him getting up and getting to the bus. And I think mom providing that support. A lot of times, with a lot of his medical issues, he'll say he doesn't feel well or he's sick. And so, school has been working with them on the truancy issue. So, yeah, there's been some barriers there, but yeah, he does take the bus to school, and there's been a lot of intervention there. I'm currently working with her on, since he had the cord procedure, that in August we get back to school, and I'm going to reach out to the school social worker there to try to see what we need to do just to set them up for success from the get-go. And I've really done some behavioral intervention with mom saying, there's some times where he just doesn't feel like going because he may be tired, and, making sure we follow that good sleep pattern so he can get up and go to school. But just because he says he's sick isn't a reason to keep him home,
Yeah.
because a lot of times that's what she'll do. And he really is okay to go to school. I don't know, Dr. Ortega, if you have something to add to that, but good points. I appreciate you asking that.
We need to move to recommendations. This is a wonderful case, and I wish we had a little more time to discuss the case. But are there any recommendations from our participants of what you think would be the best solution?
We will take any feedback and recommendations, trust me.
I will ask, is anybody familiar in recommendations? I've worked with a lot of children's division, but not Morgan County, and I'm having a difficult time to reach them. Is anybody familiar? Are they good with providing services, or are they quick to open and close cases? Any providers have experience with that? Or I think there's another social worker on here, I heard.
Yeah, this is Heather Allen. I'm with the Children's Division. I'm trying to reach out to our prevention unit manager and see where I can get the family connected. So if you want to send me your email address, and then that way I can make sure that it gets to her and whoever we can get you connected with. So that way, because we don't want the family to continue to keep experiencing issues and then potentially the Children's Division get more involved. We would like to have, supports put in place so that way our services like foster care, if it comes to something like that, would not be needed. So
that's awesome, Heather. I really appreciate that, because that's what I've explained to mom. She's of course very scared every time a report's made, and I've reassured her that the first step is to just get some support services to help support you so that he can stay in the home. I'll put my info in the chat here. Thank you so much.
Thanks, Heather. Other recommendations from participants or from the hub team?
I just want to point out that was a huge thing that just happened, and I don't think we've ever had anything like that through. And it's just blowing my mind that lives are going to be bettered because of this echo. So thank you so much, Heather and Renee and Adrian for presenting this important family. My advice is just to keep supporting that mom and that family. So. And you guys have probably already done this, but any resources that may be available to them with SNAP or utility assistance, or I was thinking maybe big brothers, big sisters, if there's something like that in that county, that might get them a little bit of relief and some access to maybe some other activities and get out of the house. And then just any kind of access to healthy foods. I don't know if there's like a food bank or something like that in that area, but those are just kind of some ideas that I had. But it's so challenging when there's so many things going on and it's just chaos and, you know, resources are limited. So great work.
Thanks, Amy. What else? If this is your patient, what would you do?
This is Robin, and I'm a dietitian. I don't recall whether it was stated whether he and the family had actually met with a dietitian, but certainly I would recommend that, especially with celiac disease, and working with the family on, and you know, if there's food insecurity, how to choose your gluten-free products so they can make healthy meals that are going to be less expensive for everyone in the household.
Thank you, Robin. Excellent. Any others? If there's any food resources for them, as Amy suggested, as I wonder if any options are even available for them, and food concerns of a young man and what might be available at the next opportunity. I assume that these are all telehealth visits. Or are you seeing them in person? Yeah.
For the most part, yeah.
Yeah, which makes it a little bit more limiting. I mean, it's still certainly better than nothing. Anything else that anyone would like to suggest? Well, let's go ahead and wrap it up, even though there's probably many more things that we could possibly suggest. In terms of the case, this is a 13-year-old boy who I would just say with a capital dysregulation in terms of most areas of his life. And he's got class 3 obesity. He has had experienced hyperphagia, binge eating, ADHD, depression, anxiety, and several other comorbidities. The mother and the father also experienced obesity. The mother has had bariatric surgery. The father has had a stroke and so now has been hospitalized and expected to go to rehab. The mother is trying to change to make foods healthier. They live in a rural area, and so they have a lot of barriers in that area. They do have a weekly caseworker who is working with them. They see Children's Mercy, Dr. Ortega, and Renee from time to time, but it's not really very, very often. They tried topiramate. He stopped it because he didn't tolerate it well. They stopped the semaglutide as well. He did tend to have some weight loss during that time, but again, had a lot of side effects from it. They live in a trailer in a rural area. Sometimes they don't always have the utilities they need in terms of electricity, don't always have hot water. And now at this point, the mom and dad are the mom and the patient are living with a grandfather as the father is in the hospital. He's had trauma at school. He's had bullying. There was a sibling that died of SIDS. The father's experienced post-traumatic stress syndrome. And so he's had excessive absences at school. And so now he's doing a homebound program. And so he does night eating, doesn't have regular eating times or foods, lots of large portions, lots of high carbs. They tend to eat out more while with dad in the hospital. His sleep, he tends to be up late, multiple hours a day playing video games. There's difficulty setting limits. There's just so many factors coming in that there's lots of dysregulation. He does have a dog that he plays with. He has class 3 obesity, BMI of 49.49. He's been hotlined several times to DFS, and one of the recommendations is that possibly in-home services could be offered. And Heather was able to probably link Dr. Ortega and Renee with his county, with some of the people that are working with him. And so generally it's just putting out fires, kind of one thing after another, that makes it very difficult for this young man. He's very sensitive, thinking that perhaps he's being called fat or overweight when suggestions are given. So some of the recommendations are that Heather is reaching out to DFS to see if there can be a connection made with a person who can actually make some changes, and keeping support for the mother and the family. And maybe there are things such as big brothers, big sisters, anything that he can access that can support him in the area where he lives. Are there accesses to healthy food? Are there some food pantries that could provide a little bit more for them so that they can choose foods that are not bad for his celiac disease, gluten-free foods that would be available. And then also, if they have not met with a dietitian, if they can meet with a dietitian and discuss things that would be helpful for the weight, but also helpful for the celiac disease. And just to know what things have gluten in them. And so, excellent presentation. Thank you so much for this case. Thank you for the comments and thank you for the suggestions. And hopefully there will be some help that can be received as you're able to link up with the DFS. I just want to mention, thank you all for joining today. This is our last ECHO for this season, and we will start again in August. And so we hope that you will all join again, and hope that you'll have a wonderful summer. And we'll say goodbye to you now, but would ask the Hub team to stay on for just a minute. Thank you again to our participants. Thank you again to our presenters and our case presenters. You did a great job.
I just had one comment.